Welcome to the Health Headliner podcast by Tudu Digital. Our content is informational only and not medical advice. Please consult your provider. Now, let's dive into today's headlines.
Okay, so let's just jump right in and unpack this. For years, for decades, when you talked about treating clinical depression, the conversation really only had two main pillars.
That's right. It was either psychological therapy, things like cognitive behavioral therapy, or it was medication, antidepressants.
Exactly. And physical activity. It was always kind of there in the background. It was the thing that was recommended as a helpful supplement, a sort of nice to do.
A nice to do, but not a core treatment.
But what if that nice to do is actually a mainline treatment option? What if it can stand shoulder to shoulder with those established gold standards?
Well, that's the surprising, almost counterintuitive headline we're digging into today. The evidence suggests that for adults dealing with depression, physical activity may reduce symptoms to a very similar extent as therapy or medication.
And this feels like a genuinely pivotal moment in mental health research. It forces a pretty radical reconsideration of how we rank treatments.
It really does. It's all about this question of parity. We're talking about the potential for exercise to be elevated, not just as something you do on the side, but as a genuine evidence-backed first-line option.
The need for this is just immense. Depression is a global health crisis. We're talking well over 100 million people worldwide.
Yeah.
Finding treatments that are effective, accessible, and, tolerable is a massive social priority.
Absolutely. So that's our mission in this deep dive. We are focusing on a major updated systematic review. It was published in the Cochrane Database of Systematic Reviews in January 2026.
When you hear Cochrane, you really need to understand that this isn't just one study. It's a synthesis of the best available evidence out there.
The highest quality.
So we're going to dissect the findings, clarify those critical head-to-head comparisons, exercise versus therapy, exercise versus pills, and then really explore what this means for treatment guidelines, and I think most importantly for you, the person making choices about your own mental health care.
To really get the weight of these findings, we have to start with the source itself, this updated Cochrane systematic review.
What makes a Cochrane review so special?
Well, they're sort of the pinnacle of evidence synthesis in healthcare. They follow these incredibly rigorous, predefined protocols for finding, evaluating, and then combining all the relevant high-quality evidence on a specific question.
So it's not about one shiny new study. It's about looking at the entire global body of trustworthy research on a topic.
Precisely. It's a massive quality control filter on the science. And the scope of this particular filter is just enormous. The research team wasn't just looking at new data. They were updating previous findings and pulling in more recent trials.
And in total, they examined 73 randomized controlled trials.
73. And for anyone listening, randomized controlled trials, or RCTs, are the gold standard of clinical evidence. You randomly assign people to get either the treatment, in this case exercise, or some kind of comparison.
And that randomization is the key part, right? It minimizes the chance that something else, like personality or other health issues, skewed the results.
Exactly. So when you can synthesize data from 73 of these studies, you are building an incredibly solid foundation of evidence.
And we're not just talking about the number of studies. The sheer volume of human experience here is staggering. The total number of participants across all these trials was nearly 5,000 adults with depression.
Just shy of 5,000, 4,985 to be exact. That's an ocean of data. Imagine the work involved in synthesizing 73 highly technical papers to answer this one question.
That kind of sample size gives the findings real statistical power. It helps confirm that the results are consistent across different types of people and different settings.
So with this huge database, what were the key questions they were trying to answer? They set up 3 really distinct comparisons to see where exercise fits in.
The first one was the baseline, really, just proving it works at all.
Right. Comparison 1 was exercise compared with no treatment or some other control intervention.
So the control groups here were people on a waiting list, or maybe just getting what's called usual care, which might just be a check-in with their doctor now and then.
Or sometimes things like light stretching, something that didn't really count as structured exercise. This comparison basically asks, is moving your body objectively better than just passive management?
Okay, so what was the second comparison? This one feels more pointed.
It is. The second was exercise compared with psychological therapies. This is where you're directly pitting movement against established treatments like cognitive behavioral therapy.
The non-medication heavyweights going head-to-head.
Exactly. And then the third comparison, this is the one that really challenges the medical status quo.
Which would be?
Exercise compared with pharmacological treatments, so antidepressant medication. This one is vital because medication is still the most common initial treatment for depression across the globe.
And all of this is a response to that huge global health challenge we mentioned. I mean, therapy and medication work for a lot of people, but they're not perfect. There are side effects, there are barriers like cost and stigma.
We desperately need effective, tolerable alternatives. And this review is aimed squarely at providing the evidence for one that might just sidestep some of those traditional barriers.
Yeah, this is where it gets really interesting. This is the section with the actual results. After synthesizing all 73 trials, how did exercise actually perform in those three comparisons? Let's start with that baseline. Exercise versus inactivity.
The amount of data for this first comparison was huge. We're talking 57 trials and over 2,000 participants. And the result was unequivocally positive. Exercise led to a moderate benefit in reducing depressive symptoms compared to doing nothing.
A moderate benefit. The researchers gave a specific number for this, a standardized mean difference of negative 0.67. Now, we need to translate that. What does that number actually mean in the real world?
That's the critical question. A standardized mean difference is really just a measure of the size of the effect. Think of it this way. An effect size of negative 0.2 is small, negative 0.5 is moderate, and negative 0.8 is large.
So negative 0.67 is pretty solid. It's in that moderate to strong range.
It is. In real terms, it implies a change that is noticeable not just on a spreadsheet, but clinically. The average person doing the exercise would likely feel meaningfully better than the average person in the control group. It's a significant improvement.
Okay, but there's always a but, isn't there? I see a pretty big caveat here.
There is, and this is where the critical analysis really starts. Despite having data from 57 trials, the certainty of the evidence for this comparison was rated as low.
Low certainty. That sounds bad. Does that mean we can't trust the finding?
It's more of a caution light than a red light. It means the benefit was definitely observed, but the quality of many of those underlying trials had flaws. Maybe poor reporting or a high risk of bias, which we'll get into later.
So the message is, movement is definitely better than nothing. We just can't be 100% certain about the exact size of that benefit. Okay, so now for the comparison that really grabbed the headlines. Exercise versus psychological therapy.
This is where it gets compelling. The finding was striking. Exercise showed a similar effect on reducing depressive symptoms when it was directly compared to psychological therapy.
Let me just repeat that. Statistically speaking, the person who finished a structured exercise program felt just as much relief from their symptoms as the person who finished a course of, say, cognitive behavioral therapy.
On average, yes. And this is where the quality of the evidence gets much better. This conclusion is based on moderate certainty evidence.
Moderate certainty. That's a huge step up from low.
It's a massive upgrade. It suggests that the studies backing this up were generally of a higher quality and that the result, the parity between exercise and therapy, is unlikely to change dramatically with more research. It suggests movement is an equally valid non-pharmacological option.
The practical implications of that are huge. If a patient is hesitant about therapy, or maybe there's a 6-month waiting list,
then a structured exercise program now has the evidence base to be offered as a confident first-line option.
Okay, let's tackle the third one, the big one, the head-to-head with modern medicine. Exercise versus antidepressants.
And again, the finding was equally headline-worthy. Exercise demonstrated a similar effect on depressive symptoms compared to antidepressant medication. Statistically, there was very little difference in symptom reduction after the treatment period.
And I can feel the but coming.
A very big but. We have to inject that critical pushback immediately. This comparison relies on a much, much smaller set of data. We're talking only 5 trials with just 330 participants.
Only 330 people.
And because of that and other issues, the certainty of evidence for this finding was rated as low again.
Hold on. We're talking about saying exercise is comparable to medication, the most widely used treatment. But that claim is based on low certainty evidence from just 5 small trials. Isn't that a bit irresponsible?
That is precisely the caution the researchers themselves raised. They are reporting what the current data shows. In these 5 trials, the effects looked similar. But the low certainty tag means we absolutely cannot conclude this with high confidence.
So it's preliminary. Promising, but preliminary.
Exactly. It suggests the effect might be there, but we need far more high-quality research to confirm it. The current body of evidence is just too thin to make a definitive claim of true parity with medication.
And what about the long term? That seems critical.
It is, and the picture gets even murkier there. When they looked at follow-ups, so 4 to 6 months after the treatment ended, the evidence for exercise versus medication was rated as very low certainty.
Very low. So we have almost no idea if the benefits hold up.
That's the biggest gap in the evidence right now. Medication is often a long-term strategy. For exercise to be a true alternative, we need to know its effects are durable. And currently, we just don't have the high-quality data to say that they are.
So the efficacy numbers are definitely compelling, especially that moderate certainty finding against therapy. But if the effectiveness is similar, what helps you decide which treatment to choose?
This is where we have to look beyond just symptom reduction and examine things like the risk profile, the side effects.
And this is where exercise really starts to pull ahead, isn't it?
Dramatically. The review tracked adverse events, and the findings are just starkly different between the exercise and the medication groups.
So in the exercise groups, adverse events weren't really common. And when they did happen, they were what you'd expect, right? Like musculoskeletal pain, a sore joint, a minor injury.
Exactly. Physical things related to the activity itself. Now, contrast that with the known side effects of many antidepressants. We're talking about systemic issues, nausea, weight gain, significant sexual dysfunction, sleep problems.
Side effects that can seriously impact your quality of life and, frankly, make you want to stop taking the treatment.
They absolutely can. The review highlighted one trial where over 26% of participants on an antidepressant reported an adverse event. In the exercise group, it was just over 2%.
That's a huge difference.
And the nature of the events is different too. Medication can sometimes come with new psychiatric symptoms like agitation or anxiety. You just don't see that in the exercise groups.
So if you're a patient and you're worried about brain fog or weight gain or loss of libido, exercise presents a path with a significantly lower risk of those systemic side effects.
You might get a sore knee, but it's very unlikely to cause insomnia or stomach problems. It just makes it a much more tolerable option for many, many people.
It's also worth pointing out how stable these findings are over time. The lead author, Professor Clegg, noted that even though they added more trials in this update, the main findings stayed the same.
Right. This isn't some flash-in-the-pan result. It reinforces this growing conviction that movement really is therapeutic.
Which brings us to the really fascinating question, why? Why does moving your body help your brain fight depression? Let's get into the mechanisms.
Okay, so on the biological side, the big word you'll hear is neurogenesis.
Which is the growth of new nerve cells, new neurons, particularly in a part of the brain called the hippocampus.
Exactly. The hippocampus is critical for mood and memory, and it's often less active or even smaller in people with depression. Exercise is one of the most potent ways we know of to stimulate this process.
And how does it do that?
Primarily through the release of growth factors. The star player here is a protein called brain-derived neurotrophic factor, or BDNF.
I've heard this called miracle grow for the brain.
That's the perfect analogy. It helps existing neurons survive, and it encourages the growth of new neurons and new connections between them. When you do sustain physical activity, especially cardio, your levels of BDNF go up. You are literally building and strengthening the brain pathways that depression can disrupt.
So it's a direct physiological countermeasure.
It is. And beyond that, exercise is a powerful regulator of the body's stress response. Depression is deeply linked to chronic stress and high levels of the stress hormone, cortisol.
And regular exercise can sort of reset that system.
It trains the body and brain to respond to stress more effectively. It can lower resting cortisol levels and reduce systemic inflammation, which is another factor that's increasingly being linked to depression.
That covers the biological side. What about the psychological reasons?
On the psychological side, it's about directly tackling that sense of hopelessness and helplessness that is so central to depression.
So the act of setting a small goal like walking for 20 minutes and then actually achieving it.
Yes. That provides a direct, measurable sense of mastery and self-efficacy. It's a small victory that pushes back against that overwhelming feeling that you can't do anything. It slowly rebuilds confidence.
And there's a social element too, depending on the activity.
A huge one. Group classes, team sports, even just having a gym buddy. It all provides social interaction and reduces the isolation that can make depression so much worse. It provides structure.
Now, the review looked at different kinds of exercise, right? It wasn't just running on a treadmill.
No, it included aerobic exercise, resistance or strength training, and a combination of both.
And did they find that one type was better than the others?
The subgroup analyses they did are really useful here. They suggested that while all types of exercise helped, aerobic exercise and mixed exercise, so cardio plus strength training might have a slightly larger effect than just resistance training on its own.
Which makes sense.
Yeah.
Cardio is great for that BDNF boost, and strength training is amazing for building that sense of self-esteem and physical capability.
So combining them seems to offer the best of both worlds. But the key takeaway is flexibility. If a patient prefers lifting weights, the evidence is strong enough to support that as a very effective option. The goal is sustainable movement.
So we have this really compelling picture. Moderate evidence for parity with therapy, some early low-certainty evidence for parity with medication. But we have to be critical. Where does the certainty drop off? What are the big caveats you need to keep in mind?
The first, and it's the biggest hurdle for pretty much all exercise research, is the problem of blinding.
Right. You can't really do a placebo for exercise. It's impossible to convince someone who's jogging for 30 minutes that they're in the inactive group.
Exactly. They know they're getting the treatment. And that knowledge can lead to what's called performance bias. Participants might report feeling better simply because they expect to feel better. It's a powerful placebo effect.
And it affects the researchers too, right? The trainers and coaches also know who is in which group.
They do. And that can subtly influence their interactions. Crucially, the review found that while some trials were able to blind the people who assessed the final outcomes, many did not.
So the person scoring the depression questionnaire at the end of the study might know if the patient has been exercising or not.
And that knowledge, even subconsciously, could influence how they score ambiguous answers. This inability to properly blind exercise studies is the main reason the certainty of evidence often gets downgraded from high to moderate or low.
You've mentioned certainty of evidence a lot. Maybe we should break down what that grade methodology actually means. When you say low certainty, what should that signal to a listener?
It's a formal way of saying how confident we are that the effect they measured is the true effect. High certainty means we're very confident. Moderate certainty, like we saw with exercise versus therapy, means we're pretty confident, but future research might shift the estimate a little bit.
And low certainty, like with the medication comparison.
Low certainty means our confidence is limited. The true effect could be substantially different from what was measured. It doesn't mean the finding is wrong. It just means the evidence base is too weak, maybe from bias or small sample sizes, for us to trust it fully yet.
Which brings us to the next big limitation, those small sample sizes.
Yeah.
Especially for the medication comparison.
Right. 5 trials and 330 people, it's just not a lot of data when you're comparing it to the mountain of evidence that exists for antidepressants. And the duration of these studies is also a problem.
They were mostly short-term.
Very. Most of them only looked at the effects right after the treatment ended. We have very, very few robust long-term follow-up studies. We just don't know if the benefits hold up 6 months or a year later.
And that is a huge caveat. For a treatment to be a true alternative, it has to show that it's durable. The evidence for that just isn't there yet.
Then there's the practical challenge that really separates exercise from almost any other treatment. Adherence.
Actually sticking with it. If a doctor prescribes a pill, you either take it or you don't. If they prescribe 3 gym sessions a week, life gets in the way.
It does, and the review highlighted this. The completion rates in these studies were all over the map. Some trials had people adhering only about 27% of the time. Others had 100% completion.
That massive variation is so important. If the great results are based on the people who completed 100% of the sessions, how does that apply to the average person who is struggling just to get out of bed?
It's a key question. It suggests that while exercise is effective for those who do it, its acceptability and sustainability as a treatment varies a lot from person to person.
And finally, there's the issue of the dose. We don't really have one.
We don't. The review included everything from walking programs to high-intensity circuits. So while we know movement helps, we can't yet write a precise prescription.
We can't say, you need 3 30-minute high-intensity sessions per week for optimal results.
Not with the data we currently have. That's a major focus for future research, figuring out the optimal frequency, intensity, and duration for different people.
Okay, so after this really detailed deep dive, where does this leave us? What are the big implications for clinical practice and for you, the listener?
The main implication is, I think, foundational. The evidence is now strong enough to support exercise as a viable standalone treatment, or at least as an adjunctive one. especially given the moderate certainty it has against psychological therapy.
This isn't just a tentative suggestion anymore. It strengthens the guidelines that groups like 9C in the UK have already put in place.
The real takeaway is that combination of similar effectiveness but a dramatically better side effect profile. It means exercise should be presented to patients as a genuine, evidence-based alternative.
So if a patient is worried about medication side effects or can't access therapy, a doctor can now offer a structured exercise program with real confidence that it's likely to help in the short term.
It gives patients so much more autonomy and choice.
But the limitations we just covered really dictate where the research needs to go next.
Absolutely. We need better quality trials, first and foremost. Better designs, better blinding of the people assessing the outcomes, and a huge focus on long-term follow-up. We need to get the certainty of evidence for that medication comparison up from low to moderate.
And we desperately need to figure out that optimal dose.
We need that prescription. We need to know what specific characteristics of exercise, the frequency, the intensity are most effective for different types of depression.
And as exercise becomes a mainline treatment, we have to think about equity.
That's a critical point. We have to address the real-world barriers. That means access to safe spaces to exercise, making sure activities are culturally relevant, reducing the financial cost. The evidence shows it works. Now we need the societal infrastructure to make sure everyone can actually use it.
So this deep dive shows the argument for exercise being comparable to therapy and maybe even medication for reducing symptoms in the short term is based on really strong and growing evidence. So here's the final thought for you to take away. If a prescription for structured movement could carry the same clinical weight as a prescription for a pill, how would that fundamentally change your own approach to your health and your mental well-being? And what new barriers, whether they're about policy or resources or just societal norms, would we need to tear down to make that option truly equitable for everyone?
Thanks for tuning in to the Health Headliner podcast by To Digital. Like and subscribe for more health news and breakthroughs. Stay healthy and informed. See you next time.